So this is the second video that I'm doing on essentially IBD. So IBD is inflammatory bowel disease, and there are basically two different presentations of it. There's Crohn's disease and there's ulcerative colitis. About 3 million people worldwide are affected by inflammatory bowel disease. I have a separate video that covers Crohn's disease and goes into the inflammatory pathway behind that one. Okay, so let's talk about ulcerative colitis. So in ulcerative colitis, we expect to see bloody diarrhea, frequent small volume bowel movements, and it's often associated with abdominal pain, urgency, tenesmus, and sometimes fecal incontinence, okay? Just like Crohn's disease and a lot of other chronic conditions, we don't really know exactly what triggers somebody to develop this. So there's probably some genetic and environmental and then immune-mediated reasons that somebody develops ulcerative colitis. And it's kind of this group here, this small percentage of the population that would actually wind up developing disease. We do know there's some genetic component, but that's not the whole story. So the relative risk of siblings, so you and your brother and sister, there's about a 10 to 20-fold increase in your risk of developing ulcerative colitis if your direct sibling has ulcerative colitis. But in monozygotic twins, so identical twins, the risk is only about 10 to 20%. So the genetic link is there, but not exceptionally impressive, okay? But family history plays a role. There are also kind of these epidemiologic associations with different descent. Women tend to be affected more than men. That's pretty common for autoimmune diseases. Patients of Caucasian descent have a higher risk, and particularly patients of Eastern European Jewish descent tend to have a higher risk of developing ulcerative colitis. To differentiate ulcerative colitis and Crohn's disease, there's really two things that people seem to look at: location and pathology. Okay, so if it's taking place only in the colon, we're thinking ulcerative colitis. If the small bowel is involved at all, think more Crohn's disease. If the pathology is kind of discontinuous and cobblestoned, but goes through the entirety of the bowel wall and is granulomatous in nature, that's Crohn's disease. If the pathology is continuous, but only goes through the mucosa and the submucosa, think ulcerative colitis. All right, so unlike Crohn's disease, ulcerative colitis is actually classified as a type 4 hypersensitivity. The role between pathology and the activity of T cells has been very well defined. And namely the role between both CD8 cells, because they do cause damage, but also the cytokines produced by the CD4 cells has also been very well defined. Now, that's defined, but we don't know what starts it, essentially. So the etiology, the target, completely unknown. Once again, there is kind of this potential for a predisposing effect or event. So, for example, you know, you contracted ETEC while you were traveling and it was so horrible, and now your basically normally tolerogenic colon is forever skewed toward an inflammatory event. So what we know is basically there's a significant imbalance, all right? So in a healthy gastrointestinal tract, I'm just gonna kind of draw some scales, okay? You have kind of a fairly tolerogenic expression. So you have Treg cells, you have IL-10, you have TGF, you have kind of this environment that's very accepting of things that are different. You also have some early Th17 cells, which are kind of allowed to be there. They produce IL-22. You have some alpha defensins that kind of promote protection. So there is some inflammation that's always happening, but not so much that the environment isn't tolerogenic. Once you move into these inflammatory bowel diseases, though, this ratio gets horribly skewed, okay? So basically you have way too many Th17s. The small amount that was allowed to be there has just gone out of control. You have significant Th1, and as you know, Th1 leads to interferon gamma, IL-2, TNF, all sorts of pro-inflammatory cytokines that basically just perpetuate this. And that's going to lead us to less Tregs, which eventually just continues to skew this cycle so that we're making more and more of the pro-inflammatory. So we have this significant imbalance. Additionally, patients with ulcerative colitis tend to have significantly more CD8 positive T cells, which makes sense. If we're making a lot of Th1 cytokines, we're actually helping to prime more CD8 positive T cells. So we'll see more CD8s in the epithelial lining of the colon, which may play a role in destroying the lumen of the colon. The other thing, when we have all of these cytokines, it's not impossible that B cells are going to get involved. And that's actually what we see. So patients with ulcerative colitis will also have p-ANCA antibodies in their serum. These are perinuclear anti-neutrophil cytoplasmic antibodies. These antibodies essentially target neutrophils. So why would they target neutrophils? Well, there's kind of two thoughts in their targeting. They could be targeting neutrophils because the neutrophils look like something. This is a case of mistaken identity, and that's known as molecular mimicry. Basically, the antigen on the neutrophil looks enough like the actual intended target of this antibody that it's binding the neutrophil and killing it. The other option, though, is that it's actually resulting from the overwhelming inflammation that's unrelated to any sort of infection, and that's called bystander activation. So it's not actually specific for it, but there's so much inflammation that now it's being attacked kind of by association. So therefore, we begin attacking our neutrophils and also causing death to those cells. So basically, what you're looking at with ulcerative colitis, even though we don't know the initial etiology or the target, is the gross imbalance of the normal inflammatory pathways within the gastrointestinal tract. Okay, so how is diagnosis of ulcerative colitis made? It's based on the presence of chronic diarrhea for greater than 4 or more weeks. You also have to show active inflammation on endoscopy and chronic changes on biopsy. And the other thing is you should definitely rule out other potential causes for this. For example, C. difficile. That's a major cause of chronic diarrhea. So you want to make sure that it's not that your patient has something else. So recent use of antibiotics could also be an issue. So you just want to make sure that it's not C. diff before you decide they have ulcerative colitis. How do we treat it? Basically, treatment revolves around reducing the inflammation in whichever way possible. So you can use anti-inflammatory treatments. So immunosuppressants I'm trying to say immunosuppressants, and instead I wrote in treatments. So immunosuppressives would actually be pretty effective here and have been being used to help that. So corticosteroids like methylprednisone can be used to reduce inflammation during a disease flare. Some cell cycle inhibitors have also been thought of. So what about surgery? Yeah, surgery is technically an option. Surgical removal of the colon and the rectum is curative. But you have to think about what that's going to do to the patient if you remove their colon and rectum. As the disease affects all of this, remember this is a continuous pathology, unlike Crohn's. So if you remove the colon, you could take care of it. The operation, though, is going to leave the patient with either an end ileostomy or an ilioanal anastomosis, i.e. a pouch, with significant diarrhea as the sequelae. So you're kind of in a bit of a pickle here because the presentation is chronic diarrhea. But if you remove the colon and the rectum, the likelihood is diarrhea. So the question is, are you willing, what is the kind of disease state of the colon at the time, the pain, the clinical presentation that would lead a surgeon to potentially make that suggestion?